This conference will now be recorded.
Yeah, hello everyone. Welcome to day 2 webinar. A very good morning, afternoon, or evening to one and all present here virtually with me today. My name is Razina, Conference Secretariat at Coalesce Research Group LLC, and I will be available for any of your queries and questions throughout the webinar to help you out technically and organize the webinar successfully. So starting our first session is by Dr. Cristiana Carvalho from University of Coimbra, Portugal. Hello, Dr. Christina. Are you ready with your
Hello.
presentation?
Yes,
Yeah, okay. I'm going to make you the presenter.
thank you.
Yes, you can share your screen with us.
Okay, you can see it?
Yes, perfect.
Okay. Let's just okay. I'm just trying to put this smaller, sorry. Okay.
Okay, no problem.
So good afternoon to all of you. My name is Cristina Carvalho. I work in the University of Coimbra in Portugal. And I would like to thank the organizing committee for having me here to present my work that is called Zafra 131 Prevents High Glucose-Induced Neuronal Death through Improvement of Mitochondria and Autophagy Defects. So I'm trying to, it's not, okay.
Yeah, you can click on the
Yeah,
mouse.
it wasn't going, but now I found the place, sorry. So over the last decades, the number of metabolic disorders has increased exponentially. And this is mainly due to changes in the lifestyle factors and the increase in the calorie intake. Among them, type 2 diabetes is the most common form of metabolic disorder and is mainly characterized by an insulin resistance that is responsible for the impaired glucose tolerance and increase in blood glucose levels. Presently, World Health Organization says that to diagnose a patient with diabetes, he has to have a fasting plasma glucose superior to 7 millimolar, or an increase in the 2-hour plasma glucose levels on an oral glucose tolerance test superior to 11.1 millimolar. And presently, the number of diabetic cases is already considered epidemics. And it's expected that in a 4 years frame, the numbers will rise exponentially. And we believe that the data will be even worse than what is expected due to the successive confinements that we are suffering from COVID-19 that are not only changing our lifestyle, but is also altering the follow-up of diagnosed patients, leading to improper follow-up, but also delaying the new diagnosis of patients. And this is very important because type 2 diabetes can lead to serious life-threatening problems such as stroke, blindness, heart disease, kidney disease. And importantly for our work, it is known that type 2 diabetes is a second major risk factor for the development of neurodegenerative diseases, namely Alzheimer's disease. So due to the diabetes pandemic and the exponential growth that we are seeing in the population worldwide, it is urgent to clarify the mechanisms that underlie type 2 diabetes-associated brain damage in order to find the effective strategies that will allow us to avoid or delay its progression. We previously show in our group that type 2 diabetes, and in this case Alzheimer's disease, that is the most common form of dementia, that both pathologies share several common features, such as the vascular anomalies that are closely related with mitochondrial alterations and oxidative stress, but also they share several cellular and structural changes that are responsible for changes in the behavior and cognitive function. So, although we already saw that mitochondrial dysfunction is a common denominator between both pathologies, what causes this mitochondrial dysfunction is still a mystery. And here I'm going to present you the WW domain containing oxyreductase that was initially described as a tumor suppressor, but that presently has revealed to have several key roles in molecular interactions signaling metabolism and apoptosis. More importantly, this protein is known to be activated under stress conditions, where it's phosphorylated at tyrosine 33. It forms a complex with p53 and goes to mitochondria and nucleus, and once inside mitochondria, it can be responsible for a cytochrome C release and the activation of apoptosis. And recently, this protein was also demonstrated that she was involved in Alzheimer's disease. And in 2017, there was a study that showed that the specific inhibition of WOX with Zafra was able to restore memory deficits in the triple transgenic mice of Alzheimer's disease by blocking the aggregation of A beta and tau, the two main hallmarks of this disease. So we wonder, okay, if we have a common denominator between type 2 diabetes and Alzheimer's disease, and if this protein seems to be involved in the development of AD, is it involved also in type 2 diabetes associated neurodegeneration? So we went to see in two different animal models, that is the Goto Kakizaki rat and the high-fat induced animal model for diabetes, what was happening to this protein. And what we saw is that in both animal models, there was an increase in WOX activation through its phosphorylation, especially at the younger ages. Moreover, we also saw that under high glucose conditions in vitro, there was an increase in cell death that was associated with a decrease in mitochondrial membrane potential and an increase in mitochondrial ROS production. But what was interesting in this study was that the increase in WOX activation through its phosphorylation seems to occur previous to the damage in mitochondria and cell death, so supporting our hypothesis that WOX can be involved in diabetes neuronal damage. So, knowing that the involvement of this protein in hyperglycemia-associated conditions was never explored, we tried to see also if the inhibition of WOX with Zafra 131 was able to inhibit the WOX phosphorylation and the damage that hyperglycemia leads to mitochondria. To this, we used the differentiated neuroblastoma cell line, and we performed normal and high glucose incubations for 48 hours. And we did two different kinds of approaches for WOX inhibition. We performed an early intervention that was given 3 hours after the beginning of glucose incubation, and a late intervention where we give our inhibitor 24 hours after the glucose incubation starts. We start by seeing if our approach were being effective in inhibit the WOX activation, and indeed we saw that under hyperglycemic conditions there was the increase in phospho-WOX as previously, but that when we give both kind of approaches, early or late intervention, we were able to inhibit its phosphorylation. Next, we went to see p53 that, as I told you before in my talk, WOX binds to p53 to go to mitochondria and cause the damage. And here we saw that under hyperglycemic conditions, p53 was also increased, and the inhibition of WOX leads also to a decrease in its levels. So next we went to see previous analyzed parameters, and we saw that WOX inhibition was able to decrease cell death through inhibition of cascade activation. And we also saw that the inhibition of WOX was responsible for restoration of mitochondrial membrane potential and decrease in mitochondrial ROS production. So next we went to see how mitochondrial respiratory chain was working, since neuronal cells are very prone to energy changes, and mitochondria is the major source of ATP in these cells. And what we saw is that high glucose leads to alterations in mitochondrial respiratory chain, to a reduction in basal levels of respiration, increase in proton leak and decrease in ATP production, as well as decrease in mitochondrial coupling efficiency. And when we give the WOX inhibitor to these cells in these conditions, we were able to restore all these parameters, restoring the ATP production for these cells. So, besides the mitochondrial respiratory chain, we know that to maintain a healthy pool of mitochondria, a strict balance between mitochondrial dynamics, mitochondrial bioenergetics, and autophagic clearance is very important to maintain the homeostasis in cells. So we start to see what was happening to mitochondrial dynamics in our conditions, and what we saw is that under high glucose conditions, there was an imbalance between mitochondrial fusion and fusion process, and that when we inhibit WOX, there was a normalization of the levels of the proteins involved in these processes. We also went to see biogenesis, and what we saw is that we have an accumulation of some of the mitochondrial subunits, such as MTCO1, complex 2, and this suggests that there is an increase in biogenesis, like we saw here for the increase in NRF1 levels. However, we believe that although we have an attempt to maintain the healthy mitochondria through biogenesis, we may also have an improper assembly of mitochondria because some of the subunits doesn't follow the tendency to increase. They instead decrease, such is the case of ND1 and VDAC. So this suggests that we have an accumulation of unhealthy mitochondria in our cells. So we went to see if this was just increase in biogenesis but not properly assembled, or if autophagic clearance was also compromised. And what we saw is that we start by having a problem in the nucleation phase of autophagy, where it seems to have backlink seems to be bind to BCL2 in excess instead of going to P3K and form the initiation complex. Interesting, always when we inhibit WOX, we seem to normalize the protein levels in all these processes. Next, we went to see the elongation phase of autophagy, and again we saw that there is a deregulation in this phase of the process to a decrease in ATG7 levels, that leads to an accumulation of P6G2 and alterations in LC3-2 ratio. Again, when we inhibit our cells with the WOX, with our specific inhibitor, we were able to rescue all these alterations. So together, our results show that WOX activation can be underlying the high glucose-induced neuronal damage and death, and that the ZAFRA131, the specific inhibitor of this protein, can be a therapeutic approach in hyperglycemia diabetes-associated neurodegeneration. So to answer the question, is WOX a mechanistic target in type 2 diabetes-associated neurodegeneration? We believe that the answer is yes. Finally, I would like to thank all the people involved in this work, especially my supervisor and my teamwork group, Dr. Raquel for the animals colony, FCT for funding, and you for listening. And I'm available to answer any questions you may have.
Yeah, thank you, Dr. Christina, for your presentation. Is anyone having any questions? Okay, no questions. Thank you once again for your presence and presentation.
Thank you.
Okay, so our next presenter is Dr. Thomas Nettikaden from Canadian Centre for Agri-Food Research in Health and Medicine, Canada. Hello, Dr. Thomas.
Hello.
Are you ready with your presentation?
Yes.
Okay, I'm going to make your presenter. Yes, please share your screen with us. Yes, it's visible.
It's visible? Okay.
Yes, you can start your presentation.
Hello everyone. My name is Thomas Nitikaran, and today I will be speaking on the effects of resveratrol on the heart as its cardioprotection. So, for those of you who are not in this area, heart failure is a medical condition where the heart is unable to pump sufficient blood to different parts of the body. Coronary artery disease, which is often referred to as the ischemic heart disease, is the most common cause for its development. And some of the causes for the development of coronary artery disease include hypertension, obesity, diabetes, and aging. Despite the success of existing therapies, coronary artery disease remains to be a major cause of death worldwide. Accordingly, there's an important need to explore the new heart failure therapies to complement the existing medications. In this regard, cardiac glycosides, which are derived from flowering plants known as foxgloves, have been used in generations in the treatment of heart failure. And today I will give you, we will talk about resveratrol, which is a polyphenol found in grapes and in other medicinal plants such as Japanese knotweed. I'll give you some evidence of resveratrol being useful, maybe a potential therapy in heart disease. So again, coronary artery disease is a condition which occurs when there is a block in the coronary artery vessels, and these are vessels which feed the heart. And this results in a decreased flow of blood to that part, causing damage to that localized area, as you can see in this figure here. And it's termed as myocardial infarction. And in layman's terms, it's referred to as a heart attack. If this condition is left untreated, coronary artery disease will transition into heart failure. The most successful heart failure medications target a signaling pathway called the angiotensin signaling pathway. So the angiotensin receptor blockers and angiotensin converting enzyme inhibitors have been found to be the frontline medications for treating patients with heart failure. In fact, between the two, angiotensin converting enzymes is considered as the frontline medication for patients with heart failure. So our objective was to examine whether resveratrol can arrest cardiac abnormalities in cardiac abnormalities in this in an animal model of heart failure due to myocardial infarction, which was created by blocking or occluding the coronary artery, and this results in myocardial infarction, as is seen in here in the blue part. The study design included animals which included coronary ligated Sprague-Dawley rats and its control sham ligated rats. The dose of resveratrol and perindopril, which is the angiotensin converting enzyme inhibitor, was 2.5 milligrams per kilogram body weight per day. The treatment was done by oral gavage. 6-week animals underwent surgery or treatment, and the study was terminated at 14 weeks. We measured the tibia length and also estimated the heart, lung, and liver weights. We also examined heart structure and function by 2-dimensional M-mode echocardiography and pulse wave Doppler echocardiography using this ultrasound machine seen on your right-hand side. So first we examined the left ventricular internal dimension. That is this space which you can see pointed out by the green arrow. In a normal condition, it looks like this, but in an abnormal condition such as dilated cardiomyopathy, the space increases. So basically this is termed as dilation, where there's an accumulation of fluid, etc. And it's an early sign of heart failure. So our results show that the left ventricular internal dimension was significantly increased in the MI or the myocardial infarction group compared to controls. And as you can see here, all three treatments, perindopril, resveratrol, and the combination were able to successfully lower this dilation in the MI rats. Next, we went on to examine the wall thicknesses. So here you see the left ventricular posterior wall and the interventricular septum. The interventricular septum is the one which separates the left and the right ventricle. As in a normal case, is the figure seen above, but in an abnormal case, there is a thickening of both the walls, the interventricular septum and the posterior wall, causing a condition called hypertrophy, which is a sign of heart disease, which eventually leads to heart failure. What we observed was there was no change in the left ventricular posterior wall in any of the groups. However, instead of an increase in the wall thickness of the interventricular septal wall, we found a decrease. Now the decrease in the MI group compared to control. Now a decrease is also considered as a sign of disease, of heart disease, because a thinning of the ventricle is basically loss of its cells and loss of its function eventually. However, none of the treatments, perindopril, resveratrol, or the combination were ineffective in reversing this decrease. So because we saw structural abnormalities, we wanted to see if it translated into any defects in the heart function. And what we examined the left ventricular ejection fraction, which is the pumping of the heart, which allows the heart to pump blood to different parts of the body. And what we see here is a significant decrease in the left ventricular ejection fraction in the MI group compared to controls. All three treatments were successful in recovering this decreased function in the MI rats. So in summary, in comparison to controls, 8-week MI rats presented with defects in both the structure as well as function, that is dilation of the heart, a thinning of the interventricular septal wall, and a loss of ejection fraction. And these 8-week MI rats, when treated with resveratrol, perindopril, or the combination, resulted in an improvement, or rather a reduction in the dilation of the heart and an improved heart function. However, we were excited to see that resveratrol was as effective as perindopril in improving cardiac structure and function in MI rats. Nevertheless, the combination of resveratrol and perindopril was not better than in comparison with either treatment alone. So in this study, we also went on to assess the heart tissues for oxidative stress and antioxidant activities. As you all know, polyphenols have got one of the main properties of polyphenols is its antioxidant property. Besides many other properties like anti-inflammatory and anti-apoptotic, but oxidative stress seems to be the central feature of polyphenol. So we went on to examine this particular characteristic using by performing activities using commercially available kits. What we found was that there was a significant increase in oxidative stress. That is, we examine MDA, which is a marker of oxidative stress, in the MI rats compared to its controls. And all three treatments were successful in lowering this increased oxidative stress in the MI rats. In this study, we also examined in the tissues both the antioxidant activities, that is superoxide dismutase and catalase. And what we see here is that the activity of both SOD and catalase was significantly decreased compared to its respective controls. And all three treatments were able to successfully recover this decreased activities of both antioxidant enzymes in the MI rats. So to just summarize this section, in comparison to controls, 8-week MI animals presented with oxidative stress and decreased antioxidant enzyme activities. And 8-week rats treated with resveratrol and perindopril alone or in the combination also resulted in an improved antioxidant activities, and which perhaps has led to a reduction in the oxidative stress. So the results from these in vivo studies led us to examine in deep the role of antioxidant molecules at the cellular level, and to examine whether these antioxidant molecules played any role in the resveratrol mediated cardioprotection, for which we worked with cardiomyocytes. These are heart muscle cells which contract and relax, these from rat hearts. So our design included cardiomyocytes which were isolated from adult rat hearts. One group of cardiomyocytes was exposed to norepinephrine, which is a potent inducer of cell death. The other group, which was not exposed to norepinephrine, was treated as controls. One subgroup of norepinephrine exposed cardiomyocytes were treated with resveratrol. The methodology included assessment of the ratio of the rod-shaped healthy cardiomyocytes to round-shaped unhealthy cardiomyocytes. As you can see in the panel above on your right-hand side, these are the cylindrical cells are the healthy cells, and the rounded cells are the unhealthy cells. And we did this using this particular microscope. Our data shows that, as you can see on your left-hand panel, the first panel on the left, there is a big number of cylindrical rod-shaped cells in the normal isolation. However, when these normal cells are exposed to norepinephrine, you can see how many cells have got rounded. That is, there is the presence of unhealthy rounded cells. And with the treatment with resveratrol, you can see there is a significant rescue in the number of rod-shaped cells. And this is below is just a graphical representation of the data shown in the figure. We next went on to examine the function of the cardiomyocytes, that is called contractility. So we use this video-based edge detection system to measure the rate of contraction and the rate of relaxation of these heart muscle cells. And what we see here is, in comparison to its respective controls, both the rate of contraction and the rate of relaxation is significantly reduced in the norepinephrine exposed group compared to controls. And treatment with resveratrol was able to significantly rescue the decreased rate of contraction and rate of relaxation in the norepinephrine exposed groups. We also examined the status of oxidative stress, and as you can see here, there was a significant increase in the level of oxidative stress in the NE exposed group compared to control, and resveratrol treatment was able to significantly lower it in the NE exposed cardiomyocyte group. We next went on to do a similar experiment as I mentioned before with the cardiomyocytes, with the exception that one subgroup of norepinephrine exposed cardiomyocytes were treated with inhibitors of antioxidant enzymes, as well as an inhibitor of the transcription factor of these antioxidant enzymes. And what we see here is a similar phenomena what we observed in the earlier figure. There's a decrease in the number of rod-shaped cells with NE exposure and a rescue with resveratrol treatment of the NE exposed group. However, please note that in the presence of R, which is a catalase inhibitor, and the combination of the catalase and SOD inhibitor, there was a loss of the beneficial effect which was seen in the resveratrol group. A similar phenomena is seen with the pharmacological inhibition of the antioxidant enzyme transcription factor when in the presence of a FOXO1 inhibitor, the beneficial effect seen with resveratrol was lost. So to summarize, any exposure to any resulted in a decrease in the survival of cardiomyocytes, rod-shaped cardiomyocytes, and cardiomyocytes exposed to any also resulted in a decrease in the SOD activity and increase in oxidative stress. And finally, treatment with resveratrol significantly improved cell survival and the contractility in cardiomyocytes exposed to any. The protective effects of resveratrol may in part be mediated by SOD and catalase enzyme activities and therefore lowering oxidative stress. Now, lastly, I'd like to just touch upon the current status of resveratrol and coronary artery disease research going on in the world. Our group and other groups have demonstrated that resveratrol was effective in preventing or reversing heart dysfunction in this animal model of heart failure due to coronary artery disease. There are a few preclinical studies which have been translated, and these are which have translated this the observations found in the animal studies to humans, and these are short-term clinical trials. A group of Hungarian researchers showed that treatment with resveratrol for 10 milligrams for 3 months improved heart function in patients with coronary artery disease. Similarly, in 2017, Ukrainian researchers showed that treatment with resveratrol for 2 months improved heart function in the same type of patients. More recently, in 2020, Hungarian researchers showed that treatment with resveratrol for 3 months improved heart function in patients with heart failure due to coronary artery disease or due to other causes. In this regard, in Winnipeg, in the St. Boniface Hospital Research Center, where I am, in collaboration with cardiologist Dr. Shelly Zeroth and Amrit Malik, we are currently conducting a 1-year human clinical trial with heart failure patients. These are 40 heart failure patients in the NYHA or New York Heart Association functional class 2 to 3, that is mild to moderate heart failure symptoms, and giving them resveratrol 500 milligrams twice per day for a period of 1 year. So to conclude, our findings show that resveratrol treatment improved heart structure and function in an animal model of coronary artery disease. We also show that resveratrol was as potent as a frontline heart failure medication in this animal model. The results from animal studies from our group, as well as other groups in the world, and the few animal studies on heart failure or in the MI group may show that resveratrol may have a potential in the prevention and or the treatment of heart failure. I'd like to finally acknowledge my trainees, postdocs, Pema Raj and Xavier Lewis, and my lab manager, Dr. Liping Yu, my collaborators, cardiologist, Dr. Shelly Zeroth and Amrit Malik, and my basic research collaborator, Dr. Jeffrey Weigel at the University of Manitoba. The funding was from, for these studies was from Heart and Stroke Foundation of Canada, Agriculture and Agri-Food Canada, and some provincial sources. This is just a picture of the research center and the hospital where we are, where I am in. On your right-hand side is the research center where is the basic research center. The left-hand side is the ASPER center where the human clinical trials are going on, and this is attached to the hospital. And just flowing nearby is the Red River. So it's a beautiful location, and I hope you will have a chance to come and visit us in the near future. Lastly, I'd just like to mention a special issue for those who are working in the area of resveratrol. It's an issue on the recent advances in the application of resveratrol to improve health. We are seeking both review articles and original articles, and the deadline for it is October 15th, 2021. And lastly, I'd like to thank you very much for your attention and leave you with this cartoon.
Yeah, thank you, Dr. Thomas, for your presentation. Is anyone having any questions? Okay, no questions. Thank you once again for your presence and presentation.
Thank you. Thank you very much.
So our next presenter is Dr. Sunita Singh from Navyu Kanya Mahavidyalaya, University of Lucknow, India. Hello, Dr. Sunita. Are you ready with your presentation?
Yes, I'm ready with my presentation.
Okay. So you are the presenter now. Kindly share your screen with us.
Okay, thank you, thank you. Are my slides are visible to you?
Yes, yes.
Okay. First of all, I would like to thank the organizing committee for giving me this opportunity and share my view on the topic antioxidant properties of some spices with their chemistry and mechanism of action. First of all, what is the relevance of this topic? Spices and aromatic herbs have been used since antiquity as preservatives, colorants, and flavor enhancers. Spices, which have long been the basis of traditional medicine in many countries, have also been the subject of study, particularly by the chemical, pharmaceutical, and food industries because of their potential use for improving health. Both in vitro and in vivo studies have demonstrated how these substances act as antioxidant, digestive stimulants, and hypolipidemics. Among these, the hypercholesterolemic and antioxidant properties of a few specific spices have far-reaching nutraceutical value. These beneficial physiological effects also have the potential of possible therapeutic application in a variety of disease conditions. As I did my PhD on the topic chemistry, antioxidant, and antimicrobial activities of essential oil and oleoresins of spices, that's why I'm giving you the overview of antioxidant use of the spices. Next. Spices, the new age nutraceuticals. The nutraceutical term is a combination of nutrition and pharmaceutical, coined in 1989 by Stephen L.D. Fellis, founder and chairman of the Foundation of Innovation Medicine. According to him, which described the nutraceutical as the substances that are not traditionally recognized nutrients but which have positive physiological effects on the human body. Nutraceutical and life sciences companies are beginning to proactively explore and leverage the healing, nutritive, and health benefits of spices and herbs to create fortified foods and organic medicines. If we talk about the properties of spices that are attracting nutraceutical industries, mainly include digestive stimulant, protection of RBC integrity, cholesterol lowering, anti-lithogenic, antioxidant, anti-inflammatory, and anti-mutagenic and anti-cancerous properties are attracting the nutraceutical industries. What is the need of antioxidant? It is well known that tissue damage is related to free reactive oxygen radicals and associated nitrogen degradation products. These radicals are high energy molecules that have free electrons in their outer orbits and can easily interact with other molecules and cause DNA damage. These molecules are continuously produced in the human body, secondary to some detoxification processes, phagocytosis, and energy production. Although the healthy human body has the capacity to neutralize free radicals, but due to some environmental conditions, our diet, our lifestyle, we got oxidative stress develops. There are many different types of reactive oxygen species, and many cellular and organ system level pathologies occur in the body depending on these products. Various antioxidant compounds are used in medicine to prevent these pathologies. This is the figure which shows how the balance between pro-oxidant and antioxidant occur. If there's an imbalance occurs, pro-oxidant, which is basically reactive oxygen species of free radicals, then it causes oxidative stress, which leads to cell and tissue damage, and which can be repaired by using antioxidant, which act as a protector or a tissue repair compound. This is the figure of some free radical diseases. The diseases caused by free radicals such as Alzheimer's disease, muscular degeneration, emphysema, coronary heart disease, peripheral vascular disease, osteoarthritis, colorectal cancer, prostate cancer, diabetes, lung cancer. These are all interrelated diseases which can be caused by free radicals. Then what antioxidant will do? It provides key nutrients needed by the body to neutralize these free radicals. It helps protects against cellular damage, may exhibit anti-aging benefits also. Superorat antioxidants are the body owns natural defense against free radicals. They scavenge or mop them up before they have a chance to harm. Next. This is a figure which shows how this antioxidant works. It prevents initiation reaction of free radicals, or if free radicals generate, it convert into non-radical products. If we talk about the history of antioxidants in food, it is from our prehistoric times, where smoking meat, fish, and treating food with spices is used as natural treatment for increasing the shelf life of food products. But after 1920 to 1950, the use of these natural origin additives are there. But after 1950s, it has been found that after the progress of technology and consumer attitude, synthetic antioxidants are used such as BHA, BHT, PG, EDTA, TBHQ. But again, after 1980s, it is a turn of green consumerism, where natural origin of antioxidants are used for increasing the shelf life of food products or using as antioxidants. Antioxidant properties of spices. In recent years, antioxidant properties of spices are well explored by scientific community due to its natural origin. Antioxidant properties are related to the efficiency of a substance to protect the food substance containing lipids and oils from oxidative deterioration. They control the rancidity process and retard the formation of toxic oxidation products. Due to natural origin of spices and increasing attention towards green consumerism, use of spices as an antioxidant alternative is an emerging research area. There are also some side effects found in these synthetic antioxidants such as BHT and BHA, butylated hydroxytoluene and butylated hydroxyanisole, which have been widely used for many years for retarding lipid oxidation. But there are some side effects which also contribute carcinogenesis. There are several studies that consider antioxidants as defense mechanism in the body against cardiovascular diseases, cancer, arthritis, asthma, and diabetes. Synthetic antioxidants used nowadays in foods such as propyl gallate and hydroxytoluene have been related to carcinogenesis promoters, so that there is a strong tendency for the use of natural resources of antioxidants. These are some of the spices which are used as a source of antioxidants such as saffron, curcumin, cumin, cinnamon, ginger, black pepper, red chili. All these are very good sources of antioxidants. There are various determination methods for antioxidant capacity of spices. For determining the antioxidant activity, antioxidant efficacy, or efficiency of spices and herbs, several analytical methods were employed: DPPH, FRAP, ORAC, total phenolic content, CUPRAC, TRAP. All these are the most frequently used methods. The antioxidant activities and antioxidant capacities of compounds obtained from spices also depends on the analytical method used. In many cases, solvent extract and temperature have significant effect on the antioxidant activities of spices. These are some of the antioxidant activity assessments: how we prepare the extract, Tolox equivalent antioxidant activity, capacity. These are total phenolic content. If we talk about the phytochemical composition of spices, it mainly includes phenol, sulfur compounds, or terpenes. Phenols are next classified into phenolic acid, lignans, tannins, stilbenes, flavonoids, whereas sulfur compounds are further classified into sulfides, indoles, glucosinolates, or isothiocyanates. Terpenes are also classified into carotenoids, limonoids, monoterpenes, saponins, sterols. All these are found in terpene class. These are some of the structure of the major component of these spices, such as gingerol of ginger, capsaicin of red chili, curcumin of turmeric, eugenol of clove. Chemistry of spices which involved in antioxidant mechanism. The antioxidant compounds such as flavonoids, polyphenolates, terpenoids, lignans, sulfites, carotenoids, saponins, coumarins, plant sterols, curcumins, phthalates present in spices are mainly responsible for their antioxidant properties. These compounds were largely determined by chromatographic methods. The antioxidant ability of spices are characterized by their ability to prevent free radical formation, remove radical, repair oxidative damage, eliminate damaged molecules. The most effective antioxidants act via interrupting the free radical chain reactions. These compounds donate hydrogen radicals to the free radicals formed during oxidation, becoming radicals themselves that are stabilized by resonance delocalization. The major component responsible for the antioxidant properties of spices are phenolic compounds, which are indirectly linked with the efficacy of antioxidant property of spices. More than 425 herbs and spices are investigated for their antioxidant properties by Carlson and workers, where clove has the highest mean antioxidant value, followed by peppermint, allspice, cinnamon, oregano, thyme, sage, rosemary, saffron, and estrogen, all dried and ground with mean values ranging from 44 to 277 millimole per 100 grams. Many researches were done for investigating the antioxidant potential, which reported the presence of antioxidant properties is predominantly in rosemary, oregano, pimento, thyme, eugenol, curcumin, gingerol, carvacrol, thymol, pimento, and capsaicin are the major compounds responsible for the antioxidant activity. These are some of the major antioxidant compounds found in some spices: clove, turmeric, ginger, mace, marjoram. It was also found that antioxidant combinations and synergism has also effect. Since each spice contains a wide range of phenols, many of them can provide synergistic effect with each other. The formulations of different herbs and spices were tested in vivo and in vitro, and their antimicrobial effects were compared. It is predicted that antioxidant effect increases significantly when thyme essential oil and vitamin E are mixed in half, so that there is a synergistic effect was shown. It has been also indicated that meats are effectively protected against Listeria monocytogenes with the combined use of curcumin and thyme. In an experimental study, it was also observed that capsaicin, the major component of red chili, was given alone, and in combination with curcumin, it reduced triglyceride levels by 12% and 21% in animals given a high-fat diet. Since piperine increases the absorption of various drugs, piperine is the major component of black pepper. It increases the bioavailability of many drugs used with other antioxidants. It increases the absorption of compounds such as coenzyme Q, curcumin, and polyphenol. For example, bioavailability of curcumin increases by 154% when it is given with piperine. In some studies, it has been presented that piperine increases the bioavailability of resveratrol in vivo by inhibiting its metabolism. In this way, it ensures that additional resveratrol doses are not required. Therefore, the combined use of herbs and spices with appropriate formulations can be recommended. If we talk about the current and future perspectives, non-traditional uses of spices include nutraceuticals now account for 15% of spice production in the country, estimated at 50 lakh ton a year. The new lines of applications are growing at a rate of 10 to 12% according to Spice Board of India. As we know that India is the land of spices, the requirement of spices by the industry is set to grow several fold in the coming year. This is not only because of the growing demand from existing operations, but also due to the efforts to develop new product lines. For example, a spice like fenugreek is understood to have anti-diabetic properties. Research is going to develop products from these spices. It is the discovery of antioxidant properties of spices that paved the way for more consumption by the nutraceutical sector. Even commercially less popular spices like rosemary and basil are bought by the nutraceutical segment for the antioxidant property. In conclusion, I would like to say that the health enhancing qualities of spices are endless, and so are their applications. Consumption patterns and lifestyles have also changed, thereby encouraging players to rev up their R&D engines and develop a range of nutraceutical products that leverage the manifold benefits of Indian spices. So don't be surprised if your energy drink or instant mix is back in a potpourri of spices in the near future. So no matter what your age, you need antioxidant. Thank you very much for listening me. Thank you.
Yeah, thank you, Dr. Sunita Singh, for your presentation. Is anyone having any questions?
Thank you.
Okay, no questions from anyone. Thank you once again for your presence and presentation. So our next presenter is Dr. Nishant Shukla from Sri V.M. Mehta Ayurveda College, India. Hello, Dr. Nishant. Are you ready with your presentation? Hello.
Yes, I am ready. And
Okay.
unfortunately, my presentation is being has been corrupted, and so I will be presenting directly as a oral presentation only.
Okay.
I may not have the presentation, but instead of that one, I am having the full paper, and I will
Okay.
share that screen along
Okay.
with that one.
Okay, no problem, doctor.
Okay, fine.
Okay. I have make you the presenter. You can share your screen with us.
Okay, fine. I'm using the camera. I'm using the mobile, and I will sharing with the presentation. I will directly speak. I
Okay,
will. I
okay.
won't have. I'm directly speaking, so I will keep my front camera, and I will speak with
Okay.
that one.
Okay, no
Yeah.
problem. You can do that.
Okay. May I start now?
Yes, yes, you can start your presentation.
Okay, fine. Very warm good evening to all of you. As per IST, it's 7:30 in the evening, and I'm thankful to the organizer for giving me chance to speak on one of the most important issue of the healthcare. As the newer news and the present scenario, the hepatic disorder is becoming one of the most important, and the incidences of the viral hepatitis is increasing day by day, and it has overcome the HIV and tuberculosis globally. So we need to focus on the management of the hepatobiliary disorders, and Ayurveda with its holistic care and management can offer a better quality life and also reduce the burden on the transplant medicine. I am here sharing some of my clinical experiences and a few cases which has been corrected and managed with the Ayurvedic medicine. Those patients were diagnosed by the leading practitioners of Gujarat, India, etc., and they were managed with the Ayurvedic medicine. In certain cases, they were managed only with Ayurvedic medicines. In certain cases, the management was combined, and this is the way I will be dealing with my presentation. Before I start my presentation and my cases, I would like to go with a brief introduction to what the Ayurveda has to say about the hepatobiliary disorders. When we talk about this one, we need to go with the ancient Ayurvedic texts. And the first evidence, the written evidence, the primary evidence is available in the textbook written somewhere in 1500 BC, approximately 3500 years back. The word used was the kamla. It is a very common disorder in India, but in ancient India, it was also present, and the classics has described the disease and the disorders related to digestion, metabolism, liver pathology, and of course the ascites and peritonitis. They are dealt with the kamla, and then after the udara roga. So this is the way which is to be there in the Ayurveda. This is I am going to share in my presentation. When we go with the Ayurvedic way, the disease has been classified into three varieties, namely the Shakashrit Kamla, Koshta Shakashrit Kamla, and Koshta Shrita Kamla. The word Shakashrit Kamla is the having resemblance with the post-hepatic jaundice. The Koshta Shrita Kamla is having the resemblance with the hepatobiliary disorders. And the third one, that is the Koshta Shaka Shrita Kamla, this is having the correlation with the pre-hepatic or hemolytic jaundice. So this is the way how the Ayurvedic description is there. In the current scenario, we are experiencing many factors which is responsible for the liver damage. This may be the management of the medicine, this may be related with the food, this may be related with the infection, especially the viral infection, which is the responsible for chronic liver damage, chronic liver failure, and may be the liver cancer also. So this is somewhere related with the Kamla itself. The management of the disease is planned as per the Koshta Shrita Kamla, and the managing this condition will be helpful to reduce the burden on the healthcare and improve the quality of life. When we discuss about the disease, the main dosha involved in the Kamla is the Pitta, according to Ayurveda. The main Pitta which is responsible for the disease is believed to be the Rajak Pitta, that is derived from the hemolysis. This is the bilirubin, and improperly conjugation of the bilirubin and the changes in this bilirubin is responsible for the typical changes in the body. So coming to all this thing, we go with how we can manage the disease and control the condition. Now, when we talk of the disease, sorry, just a minute. When we talk of the hepatobiliary disease, this is the most important one that we need to take into account. As the time is limited, I won't be able to share the complete idea of the Ayurveda about the digestion, metabolism, and the Kamla, what is responsible for the condition. Now I am coming directly to the my personal experiences and clinical successes with the use of the medicine. Now I come with here a case of a hemolytic anemia and jaundice that was diagnosed a couple of years back, the patient was from a nearby city of Rajkot and consulted me with a typical presentation of jaundice. The patient was having hemolysis, and the diagnosis was done by the hospital at Mumbai. All the hematological reports and the required analysis were done, and the diagnosis was labeled as hemolytic anemia cum jaundice. The serum bilirubin bone marrow biopsy was suggestive of the ailment. The patient was diagnosed as Koshta Shakha Shatakamla. The patient was, as it is involving the organ as well as the blood chain. That's why this was the diagnosis labeled, and the treatment was planned according to that one. The post is the organ, that is the involvement of the organ when the the liver itself is involved. It is considered as Koshtashrita Kamla, and when the blood is involved, that is the increased hemolysis, which is creating the increased secretion, increased bilirubin, then it is resulting into the hemolytic anemia, and the conjugation and the unconjugated bilirubin increases. This leads to the condition of jaundice, as you know very well. Now, in this condition, we need to correct and treat the patient at two different levels. One, we need to improve the hepatic metabolism, as well as we need to reduce the hemolysis. Now, this is to be done with a medicine which pacifies the pitta. One, second, the digestion, metabolism, and assimilation of the food needs to be improved, and thirdly, improving the hepatic health. Now, coming on to the management with these objectives, the patients were managed. The patient was managed with the classical pittagna, pittagna, that is reduces the pitta, that is a body humor which is responsible for the disease, which is responsible for the digestion. We need to correct that pitta with the use of the medications like Tinospora cordifolia, Asparagus racemosa, Glycyrrhiza glabra, and the combination of these three medicines along with certain digestive carminatives were used. These medicines were used along with the dried grape juice. Along with that one, the pravala, that is a sea product which is used in form of the praval pishti. The praval is triturated with gulab jal, that is the rose water, and this is used for the management and controlling the pitta. So this was used in the patient. The patient is improved gradually. The hemoglobin increased, direct com test reaction was reducing. The fragility test showed the improvement. The bilirubin level gradually decreased, and the patient treatment was continued for approximately 1 year. And after 1 year, the patient had no symptoms. The patient recovered well. The medicine, though, was continued for 1 more year to check any unforeseen or any untoward effect after discontinuing the medicine. And afterward, the follow-up was made for 1 year. So in total 3 years, the patient was taken care. And in those years, the patient had no untoward symptom after the use of the Ayurvedic medicine. Here, the one thing is that controlling and managing the hemolysis is one of the key area where the medicines has taken its action. Similarly, The medicines like Shatavari, Glycyrrhiza glabra, that is Yashtimadu, and Tinospora cordifolia guduchi is having the property to channelize the host defense mechanism. That is, they are having the immunomodulatory reaction, and by that one, the autoimmunity factor one, second one, the changes in the hepatocytes, they were they were return to its normal state, and in that manner the patient was passing a healthy life and the patient responded well with the medicine. Now I am sharing a second case. This was a case of viral B hepatitis. The patient was a chronic viral B hepatitis diagnosed patient. The patient was a medical professional and was in the government setup. She was diagnosed with the HBsAg and he was found positive. The patient was diagnosed somewhere in the 2000. The patient was diagnosed somewhere in 1995-96. The patient came to clinic somewhere between 2002, and the patient was examined and evaluated on the Ayurvedic lines, and the diagnosis of Kamla, that is the Koshtashrita Kamla, was labeled, and the management was done as per that one. Now here in this case, in the previous case, we need to focus on the blood and the hemolysis. In this case, the whole concentration was on correcting the digestive principle and the hepatocyte functions, that is the correcting the pitta. Here the pitta, how do we can relieve the pitta and how we can pacify the pitta, that was the main concern. And the patient was managed with the same, though the medicine used was the same, like asparagus racemosa, Glycyrrhiza glabra, and along with that one, a very small fraction in a very low dose, the irons was used in form of a triturated loha bhasma. Now, this medicine, when we talk of the bhasma or the metallic preparations, when it is used in a very low, small quantity, this triturated ions, the low bhasma, it is having the beneficiary effect. This usually, these are the sulfate formulations, and sulfate formulations are in majority of the cases are safer. The most used, when we see the classics, we found that there is a important role of the iron in management of the kamla and correcting the liver function, and so that was planned. The patient was HBsAg positive, the patient was HCV positive, and there was a changes in the liver also. The bilirubin was high, SGPT was high, alkaline phosphatase was 1282. The patient was managed with these medicines. Along with that one, the Shankhvati was used. The patient was advised to reduce the use of the fatty material, though some amount of ghee was given. Now here, the fats are responsible for the digestion, liver is responsible for the digestion of the fats. And in all liver disorders, there is need for the restriction of the fat. But in this case, as it is involving the hepatocyte cells, and there is a chances of developing the cirrhosis that, according to Ayurveda, is due to the vitiation of vata. So we need to check that one, and this can be done with the use of the sneer, that is the unctuous material, and in them the ghee, that is the clarified butter, is one of the most important material which is having that property. So the patient was given the grit along with in a limited quantity in 5 grams in a daily doses, and the patient responded well with the medicine. There was no there was marked clinical improvement, but the radiological and sonological improvement was not observed in the patient. Patient continued the medicine for 6 to 7 years, and after that, the patient collapsed. So the thing is that the average lifespan and the quality of life was improved with the medicine, and the dependency on the transplant medicine was considerably reduced. Now I am coming on to the case number 3. This is a very unique case. Basically, when we see with the Ayurvedic perspective, this is a iatrogenic disorder. But when we see with the modern perspective, there is very less relationship between these conditions. The patient was suffering from the bleeding piles. The bleeding piles was operated the bleeding piles were operated, and patient had normal post-surgical period of 1.5 months. After approximately 1.5 months, he developed the yellowing in the nails, yellowing in the eyes, and conjunctiva and skin. The patient consulted the physician, and the patient was diagnosed as hepatitis A, not hepatitis B. The patient was diagnosed as hepatitis, but not with the PCR. So the diagnosis was only the hepatitis or only the jaundice, and the patient was managed with the available medicine. The response to the patient was very minimum, and then patient came for the Ayurvedic medicine. In this case, the diagnosis, after seeing the history, the vitiated blood, which is oozing out from the bleeding piles, was stopped at once with the surgical procedure, is believed to be the cause of the liver ailment. When we see the complication of the stopping the oozing blood and that of the unhealthy nature produces the disorders like Kamla, etc. This is narrated in Charak Samhita, and you can see with that one. I will not go with the details at this point of the time. And the patient was managed accordingly. Yes, please. Any questions?
Yeah, thank you, Dr. Nishant, for your presentation. Is anyone having any questions? Okay, no questions from anyone. Thank you once again for your presence and presentation.
Okay, fine.
Okay, so our next presenter is Dr. Mayer B. Davidson from Charles R. Drew University and Mellitus Health, Inc., USA. Hello, Dr. Mayer. Are you ready with your presentation?
I just have to find out how to share it on the screen.
Yeah, I'm going to make you the presenter. Then
Can
you
you do
can
that?
able to.
And
Yeah,
can you?
just a minute.
Okay, so
Yes,
the
I have
screen.
given you the permission. Now you can share your screen with us.
All right. Uh,
Yes, perfect. Now we can able to see your screen.
yeah, but now I've got to find it on. I've got to get it up on my screen, and that I'm not sure how to do that, frankly. Sharing screen. No. Can you did I send you the slides? I don't think.
Okay, you can send us the slides if there is a problem from your side. Like we
Uh,
can able to see your screen, you can play the slides as well. Yes, it's
oh,
there.
so here. Okay, wait a minute. There it is.
Yes,
Okay,
perfect. Now it's visible.
now I've got to get rid of this screen over here.
Yeah, that will be not visible to us.
So,
We can only can see your presentation.
but I've got to get rid of all the stuff that's obscuring my presentation. Well,
Okay.
let's see what happens here. Wait a minute. So collapse. I'm gonna. Yeah, there we go. Okay, so here's the title of my talk. It's the use of computerized insulin dose adjustment algorithms to facilitate adjusting insulin doses by primary care providers. Let me get the slideshow up. That'll be the easiest way of doing it. Okay. These are the results of the landmark study of the Diabetes Control and Complications trial that established that controlling glucoses were extremely important in preventing and mitigating the microvascular complications. And this was a 6-year study, and the complications are listed at the top, the small vessel complications. Diabetic retinopathy is a leading cause of blindness in working age people. Over 50% of people are on dialysis have diabetes as the cause. The neuropathy is responsible for the 10-fold increase in lower extremity amputations. And microalbuminuria is the early sign of kidney disease. And you can see that if the A1C is kept below 7, that there's almost no increase in the relative risk of getting these complications. Over 8, you see it takes off exponentially. And this is why the ADA, the American Diabetes Association, has recommended an A1C target of less than 7 for almost all patients with diabetes. Now, these are type 1 diabetic patients. You see the same relationship for type 2 patients. People who have, this was also a 6-year study. If their A1Cs were kept less than 7, they didn't have any worsening of their retinopathy or their nephropathy, their kidney disease or their eye disease. In type 1 diabetic patients have to have insulin. In type 2 patients, the situation is that when they are diagnosed, they've already lost about 50% of their insulin secretion. And you can see here a progressive decrease in insulin secretion over time over the next 6 years. And unfortunately, no matter what we do so far, we have no drugs that will stop this progression. The sulfonylurea agents increase insulin secretion, but then it decreases at the same rate as in people treated with diet alone. And with metformin, the red curve over here, you get the same decrease in insulin secretion over time. So this means that it's easy in the beginning to treat patients who are first diagnosed with one drug, then 2 drugs. But eventually, even though we add a combination of 3, 4, and we actually sometimes end up with 5 non-insulin drugs, about 25 to 30% of patients require insulin. Now, it turns out that 90% of type 2 patients are cared for by primary care providers. And as I just said, 25 to 30% of these patients are taking insulin. And unfortunately, there is a real challenge for primary care providers in using insulin. And some of the evidence for this is on this slide. If you have patients with an A1C, hemoglobin A1C levels of greater than 8%, on 2 or more, 3 or 4 non-insulin drugs, the patients who started insulin, less than half, this is the latest data, less than half of those patients actually were started on insulin. And those that were, the median time to start insulin was 3 years, which means that over half the patients were delayed starting insulin for more than 3 years. And once they were started, many primary care providers did not increase the dose or the dosing frequency. And when insulin was started, the average A1C in our country is 9.3%. In the UK, it's 9.8%. It's a little better in Germany. And when people are usually started on basal insulin alone. And when that fails in over half the patients, the insulin is not intensified until the A1C on average was 9.7%, almost 10%. And then those that were supposedly on a stable dose of insulin, the average A1C was 8.5%. So there's a real problem in primary care doctors starting and using insulin. Now, I've been teaching doctors and nurse practitioners and mid-levels, registered nurses, et cetera, how to use insulin for over 50 years. And there are three basic principles that underlie the rules for adjusting insulin doses. Depending on when the dose is injected, each component of the insulin regimen has a maximal effect on a specific period of the 24-hour cycle, either overnight, in the morning, in the afternoon, or the evening. And the glucose pattern in that period determines whether the dose of that particular component of the insulin regimen requires adjusting or not. And the third principle is that the glucose patterns that we make our decisions on, they have to reflect the patient's usual lifestyle. So this is an example of the relationship between insulin and the different periods. These are short-acting and rapid-acting insulin. If you give it before breakfast, it affects the morning period. You give it before lunch, it affects the afternoon period. If you give intermediate-acting insulin before breakfast, it has a delayed effect and affects the afternoon. The short-acting and rapid-acting insulins in the evening, given before supper, reflect the evening. And then the overnight period is maximally affected by all the basal insulins and NPH insulin given in the evening. So using these principles, this is the results in a registered nurse, not a nurse practitioner, that after being trained, she went to work in a county clinic which served a minority and what we call under-resourced population. Her primary care providers in that clinic referred patients to her for diabetes care. They allowed her to use the protocols that she was trained on. And in 111 insulin-requiring patients, she lowered their A1Cs from 11% to 7.2% in 9 to 12 months of clinic visits. And it took her 10, 15 minutes to adjust the insulin doses at each visit. Primary care providers can't spend that much time. Their entire visit usually lasts about 15 minutes, and they have many other problems to take care of. So I took the rules that underlie the basic principles of using insulin and had them computerized. So when a patient comes to a clinic or an office visit and the meter is downloaded, within 15 seconds, a report is generated and that has the following characteristics. First of all, the computerized insulin dose adjustment algorithms were cleared by the FDA and CE registered in the European Union. They can interact with over 60 glucose meters. They handle all of the different insulin preparations, and they can analyze the results in 8 insulin regimens. These are the common regimens that are used throughout the world. It's very easy to register these patients in this program. All you need is their height and their weight and their sex or gender and just the date of birth, not the date, just the year of birth. And in this particular example, the patient is taking 60 units of NPH insulin before breakfast and 14 units before regular insulin before breakfast and 30 and 18 before supper. And that has to be registered. And then you have to register their approximate eating times and their going to bed time. And then the clinician can decide what targets they want. And these are the ADA targets that are in this example. And you get a scatter plot of all of the values, and these are the low targets and the high targets before and after each meal. And the glucose values are organized into each period. Here's the values in the overnight period, so the primary care doctor can look and see each individual value. Here is the morning period, after breakfast and before lunch. The afternoon period, after lunch tests and before dinner tests. And the evening period, the after dinner tests and the before bedtime tests. Then these values are analyzed. And in this analysis, low values below the target are in the blue, values within the target are green, high values are in the light red, and the very high values are in the dark red. And in this example, the overnight period is okay, but all the periods during the day are too high. And then the clinician gets a recommendation of how to adjust the doses. In this case, we're increasing the NPH in the morning because the afternoon period is high. We're increasing the morning regular because the morning period is high. We're continuing the NPH before supper because the overnight period was okay, and we're increasing the regular before supper because the evening was too high. Now the clinician can accept these or modify these, and then the new values, the new doses are used for the next report. So it's a big challenge in getting patients to have their insulin doses adjusted is they don't give us enough values, and they also don't come to the clinic very often. And 2/3 of patients who are taking insulin do not meet the ADA criteria. But if they could be interacted with every 1 to 4 weeks, 88% of the patients in that study did meet the ADA criteria. And so in a remote glucose monitoring, the patient is contacted by phone or email messaging without office visits, and that addresses the issue of the infrequent contact. So here's a study of remote glucose monitoring using the computerized algorithms. Certain glucose meters can be attached to a smartphone, or certain phones actually can have the glucose meter in the phone itself. And in these situations, the values go to a cloud, and our algorithms every 2 to 3 weeks go to those clouds, get the numbers, analyze them, and send a report to the clinician. And here is the results of that study. Insulin requiring patients had to have insulin for 6 months. They had to have a baseline A1C of over 8%, could not change their non-insulin drugs. Reports were sent every 2 to 3 weeks, as I said. These are minority patients, so there's only one type 1 patient. They're equal distributed in the sexes, and here is the regimens: basal alone, basal bolus, and self-mix split. The baseline A1C was 10%. At 3 months, it was 8.1%, and at 6 months, it was 7.6%. So the remote monitoring was very effective, and this was what we call a pre-post. So we compared the results before the algorithms were used and afterwards. We're now in the process of finishing up a study in which we have a control group, and the people who get the algorithms, it's a 6-month study. 32 patients out of the 42 have completed it, and they've had a decrease of 1.4% drop in their A1Cs. Usual care has about a 0.6% drop, but there's twice as much of a drop in the algorithmic patients compared to the usual care patients. So in conclusions, remote glucose monitoring utilizing these algorithms saves a lot of time for the clinicians and for the patients. With the pandemic, we're doing almost all telephonic visits now, and most patients prefer it rather than traveling to the clinics. This approach provides experience tested insulin dosing recommendations that, as I say, the clinician can modify, and it increases the frequency of the interactions, which is very important. Now, to get around the problem that patients do not like to stick their fingers, nowadays more and more patients are using continuous glucose monitoring. In this situation, a sensor is put on the patient, and patients have glucose measurements done every 5 to 15 minutes. So that takes care of the problem of the patients not wanting to stick their fingers. Now, there's a clinician challenge, however, to using CGM. The output is rather complex, and it takes a fair amount of time to evaluate it. And very frankly, at the moment, most primary care doctors don't have the experience to evaluate it. So the computerized insulin dose adjustment algorithms, this meets the clinician challenge. And here's the results of a study looking at that. And in this case, in again, another clinic that served the under-resourced patients and minority patients, When patients had A1Cs over 9%, many of them were routinely referred to a clinical pharmacist who had experience in diabetes care. And the pharmacy supplied her with 13 continuous glucose monitors for the first 13 patients who agreed to be seen every 2 weeks. The primary outcome was the usual one, A1C levels changing from baseline. But in continuous glucose monitoring, there's another outcome that's now being used. And that since we have so many glucose values, we can calculate the percent of the time that the patient spends at various target ranges. Now, the target range that we like to get them in is 70 to 180. Level 1 high is from 180 to 250. Level 2 high is over 250. And then there's 2 hypoglycemic levels. And this is a study done again, mostly with type 2 patients, basal insulins and 3 with basal bolus regimens. There were 5 reports in this study, and they occurred every 2 to 3 weeks, so that the average amount of time that the patients were followed were 3 months. And the total doses of insulin increased by 42%, and they increased by 24% in that first study that I showed you. And here are the results. Let's start at the bottom. The A1C was 11.5% at baseline. Patients very poorly controlled. And in 3 months on average, it had been reduced to 8.3%. 44% of the patients, let me rephrase that. The highest, very high level, level 2 hyperglycemia, the patients at baseline spent 44% of their time there and 26% in the high. And at the final report, this was reduced to 23% at the very high. And in the target range of 70 to 180, 29% at baseline and over 50% of the time now after the continuous glucose monitoring was done. And so you can see that what's happened here is that the glucose values at baseline in the blue have shifted downward from 44% down to only 28% at the final one. And the final one was only 23% at high over 250. And now it's 51%. This is at the end where they're in the 70 to 180 range. So continuous glucose monitoring meets the patient challenge of not testing very much. And the computerized insulin dose adjustment algorithms meets the clinician challenge because they will greatly improve diabetes control and benefit clinical outcomes, and also will decrease medical care costs. So let me finish up by showing you the effects of improving control. This is in type 2 diabetic patients, and you can see that the updated final mean A1C is related to a decrease in the hazard ratio, is a decrease in the microvascular endpoints. And for every 1% drop in A1C, you get a 37% drop in the risk of getting these microvascular complications. In type 1 diabetes, this number is actually 40%. So it has a tremendous impact on clinical outcomes. And here is the results of the financial outcomes. If people have a 1% drop and they have heart disease and hypertension, there's on average an annual savings of almost $2,000 a year. If they have only the heart disease, there's a $1,300 savings, only hypertension, $800. And if they have no complications whatsoever of these complications, there's still over a $500 savings. So the overall conclusion is that computerized insulin dose adjustment algorithms, they can be utilized at office visits, remotely, with either self-monitoring of blood glucose with a patient sticking their finger, or with continuous glucose monitoring. They will improve glucose control in insulin requiring patients. That 1% fall in A1Cs leads to a 35 to 40% decrease in the relative risk of the microvascular complications in patients with both type 1 and type 2 diabetes. There's an annual decrease in cost savings is about $500 to $2,000, depending on the baseline complications of the patient has. And so this new innovative approach to adjusting insulin doses, it should be considered by primary care doctors who care for 90% of the diabetic patients and have tremendous challenges in terms of time and many of them in experience of adjusting insulin doses. So hopefully this is a sign of the future, and I thank you for your attention.
Thank you, Dr. Mayer, for your presentation. Is anyone having any question? Okay, no question from anyone. Thank you once again for your
You're very
presence and
welcome.
presentation. Yes. So our next presenter is Dr. Neelam Kapur, Lakehead University, Canada. Hello, Dr. Neelam. Are you ready with your presentation?
Yes, I am.
Okay. So I'm going to make you the
can-
presenter.
Okay.
Yes, you can share your screen with us now. Yeah, is there any problem, doctor?
Yes, this is Dr. Horowitz. I'm having serious problems. I thought I was going to be presenting later this afternoon at 4:30. I had down in my schedule, but I'm also not able to get on because there's no passwords that are being sent to me.
Okay, can I know the name of you?
Yes, I'm Dr. Leonard Horowitz.
Yeah, Leonard Horowitz. Yeah. So what's the problem? So do you want to present now or yeah, right now the presentation is from Dr. Neelam.
No, sweetie, wasn't I scheduled for later today at 4:30 East Coast time?
Yeah, you can
16.
present it after Dr. Shamapada Mandal. As the last presenter, Dr. Mark C. is not going to present today as she is having some medical emergency. So you can present it after Shamapada Mandal.
How long is that? I mean, what time do I go on?
Yeah, it can be around 4:20.
4:20 this afternoon, correct?
Yes.
Are you on East Coast time?
Yeah, we have planned accordingly. No, I'm talking about the British summer time.
Okay, I'm on East Coast. I'm in Florida. Is that 4:30 Florida time?
Yeah, just a minute. I'm going to check it that. Yeah, is it Eastern Standard Time?
Yes.
Yeah, in that time it will be around 4:30. So it will be around 11:20.
11:20 this morning?
Yes, this morning because the program will be ending. Like it's we have left with only 3 stocks, including you.
Okay. 11:20 in this morning is in about 45 minutes, correct?
Yes.
40 minutes? Okay. Now I can prepare that. Now, how do I get on to the video conference?
Yeah, definitely. Once the conference is over, we will send you the YouTube links.
I'm confused. When the conference is over, it's over. Then I don't need any more links, right?
No, I'm not understanding. Like, do you want to present it through video presentation?
Yes, I was trying to go to meeting, and there's no password that is being sent to me.
Yeah,
Oh,
there's
Charles.
no password needed. You can just log into that. I will be making you the presenter. You can share your screen with us. There's no password needed.
Yes, I've been trying. Charles is emailing me back right now. Your talk is at 2020. He's telling me it's at 11:20 a.m. That's fine. Now he just emailed me again. If I Okay, apologies. There's no need of a password. You just log in to access code. No, it's not letting me in.
Yeah, but you are in the panel. Once I give you the presenter permission, then only you can share your screen with us.
Okay,
Till
is there
then, you can
possible?
only listen to the talks. No, there's no password needed. I have to give you the permission to share your screen.
Oh, all right. Shouldn't we try a trial run to make sure it works first?
It's not downloading in your system.
Yeah,
Here,
so
I'm
I'm going to
I'm
make
gonna,
you.
sweetie, I'm gonna put on Michelle. She's my technical advisor on this end, and she's gonna tell you what the problems are.
Yeah,
Okay.
the GoToMeeting, we're just having a problem installing GoToMeeting. It's not opening up. It keeps asking us to re-download it. Is there another format? Is it Zoom
No,
or
so how did you log in? You log in through phone?
okay, log in through phone.
No,
No,
right now you
phone.
are in the GoToMeetings, right? You
Yeah,
already log into that. If you want to share your presentation, then I need to give you permission.
we understand that. We just can't even opening it. It's having a problem. We'll have to restart your computer, Lynn. You're having an issue installing.
Check your email.
Okay, thank you very much.
Okay, you can once restart that and you can check. We can go with the presentation right now. After that, I can give you the test once you log into that. Is that okay?
I don't know. I'll try. I'm just trying my best on this end. If it happens, wonderful. If it doesn't, it's just whatever.
Okay,
Okey-doke.
you can just try once again. I can test you. I can give you the presenter. You can check with that.
Yes. Okay. We're gonna try a test. I'll try the
Okay.
test. Thank
Okay,
you.
then I'm continuing with the presentation of Dr. Neelam Kapoor. Hello, Dr. Neelam. Are you ready? You are the presenter now. Can you please share your screen with us?
I thought I did. Can you see my screen?
No, it's not visible.
Okay.
Is there any problem, doctor?
Yeah, no, I mean, I thought I shared my screen. I'm not sure why you're not able to see it.
No, it's not visible to us.
I don't know why there's echo as well. Should I just quickly log in and log out? And not sure what's happening.
This conference will now be recorded.
Can you see my screen now? You're muted.
Yeah, hello. Hello, Dr.
Yeah, I'm not
Neelam.
sure what's happening.
Yeah, this is Sherin.
I
Hi.
Can you
So
see
we
the
cannot
screen?
see your slides.
Yes.
If you find any difficulty, you can share your PPT at my email. I have pasted my email in the chat box.
Oh, okay. All right.
Hello. Hello, am I audible?
Yes, yes.
So if anyone is having any difficulty, please share your PowerPoint slides or poster or any PDFs at my email. I have copied my email ID in the chat box. Hello. Hello, Dr. Neelam. Can you hear me? You are in mute. Okay, I think it takes some time for Dr. Neelam to log in and present. Meanwhile, we'll go with next presentation.
Yeah, hello.
Yeah, Regina.
Yeah. Hello, Dr. Shamapada. I have
Yes,
given you the presenter option. Can you please
yes,
share your screen with us?
yes, madam.
Okay.
Can you?
Yes, it's visible. Your screen is visible to us.
Okay. Can you see the presentation, ma'am?
Yes, yes.
So, good evening from India, Gaurabanga University. I am Professor Samavada Mandal presenting the talk entitled Exploring the Effectiveness of SARS-CoV-2 Inhibition with Cajan bioactive compounds by molecular docking and admit profiling. This is actually a targeting research on SARS-CoV-2. We are trying to inhibit the growth or replication of SARS-CoV-2 causing COVID-19 pandemic. So this is the background of COVID-19. We are seeing that this is the scenario of cases throughout what happens in the last more than 1.5 years. This is the case number, this is number of death, and this is vaccination pattern. So this is world scenario of cases of COVID-19 till now. And this is death scenario. New death is 7,000 and total case is like this. And this is vaccination. Vaccination has been started and already it's happening throughout the world, and maximum is done in the places in the world which are deep green in color. And this is the situation of India. Look at 10 to 1900. And this is the total sketch. That means this is the pattern of the COVID-19. United States of America, the pattern is like this, and this is India. Here was the first peak, and this is second peak. That was the great bigger one, and now it is just slowing down, but not. It is on the baseline, but it has slowed. The new cases is near about 40,000, as similar as United States as well as Brazil, and the new cases are also rising in case of Russian Federation as well as some other countries like United Kingdom as well as Colombia and Argentina. But the case situation in Turkey is somewhat different. This is now slowed down, and this is the pattern of death. India in the third position, Brazil second, and United States third, first one. And this is the pattern of death till now. And India here, it's showing different types of peaks, and this was a bigger one. Now it's slowing down. And here we are seeing that in different WHO regions, such as global, the case number is 190 million. In Americas, it is more than 74 million. Europe, more than 58 million. Southeast Asian, more than 36 million. Eastern Mediterranean, more than 11 million. And Africa, more than 4 million. As well as in Western Pacific, it's nearly 4 million. And country-wise, the United States remain in first, India second, and Brazil third. Thereafter, Russian Federation, as well as France and Turkey. Here we are seeing that the cases is like this: more than 33.7 million, in India 31.14 million, and in Brazil 19.34 million. And the death count is like this. The cumulative death are here presented. It is like this, and in India the new cases is 499. So what we are doing, we have performed our study in silico, Cajan plant. This is a food plant. Its seeds are used as consume, and its different parts, starting from leaves, stems, as well bark, as well as roots, are very important as medicinal activity. Beside nutritional help with the seeds, we have targeted 3 SARS-CoV-2 protein, RDRP, RNA-dependent RNA polymerase, helicase, and H2 subunits of spike protein. This is SARS-CoV-2 causing the COVID-19 pandemic. And we have utilized some ligands from Cajan plant. These are Caja-isoflavone and Cajanone, 2 ligands, bioactive phytochemicals that shows different types of bioactivity. They can cause inhibition of growth of virus, bacteria, parasite, etc., as well as fungus. We performed ligand preparation, protein preparation, molecular docking, 3D interaction of docked ligand protein, and 2D interaction analysis through PLIP. And thereafter, we have tested ADMET, that means absorption, distribution, metabolism, excretion, and toxicity, that means pharmacokinetic studies in silico through Lipinski's rule of 5, bioavailability radar formation, as well as ADMET profiling. And these are the tools in the study. UCSF, University of California, San Francisco, Chimera version 1.15 was used for docking purpose. Pymol was used for visibility of the docked complex, that means for interaction study between ligand and protein, that means the target protein from SARS-CoV-2. Open bubble version were utilized for the conversion of one type of file to another type of file. BioVia Discovery Studio Visualizer V21.1.0.20298. This was utilized for the interaction of ligand protein both in 2D and 3D form, and PKCSM server as well as Swiss ADME were utilized for the pharmacokinetic studies. And RCSB PDB, this is web server from where we have retrieved, that means downloaded the protein structures which are RNA dependent RNA polymerase, helicase, and H2 subunit. And PubChem, from this PubChem server we have downloaded two Cajan ligand which are already presented. These are Caja isoflavone and Cajanone, and PLIP were utilized for the interaction performance between ligand and protein. Actually, the ligand and the different amino acids of the protein. And here we have already shared that 3 target proteins from SARS-CoV-2 are utilized. Helicase, its PDB ID is 6ZSL, and this is RNA dependent RNA polymerase. Its PDB ID is 6M71, and another is H2 subunit of spike protein of SARS-CoV-2. Its PDB ID is 6LXT, and their preparation was in the study with X-ray diffraction, electron microscopy, and X-ray diffraction respectively, and the resolution were 1.94 for helicase and 2.90 Armstrong for both RNA dependent RNA polymerase and H2 spike protein. And before doing the docking study in silico in RCSB, we have checked the structural authenticity of the 3 target protein obtained from SARS-CoV-2 in PDB format. So this is Ramachandran plot we have prepared in ProCheck web server, and we are seeing that when the amino acids are located in red region, that means most favored region, that means 90% or more, then it is authentic for the study. So we are seeing that the authenticity was found to study with this target protein in docking, molecular docking study. And the other additional allowed regions were 97 in number, which is 9.95%, and there was no location of there was only location of 3 amino acids. These are threonine and valine located in the disallowed region, but this is a very good structure to be used as target protein in the molecular docking study. Likewise, we are seeing that though it is not showed 90% authenticity, it's a very good target protein because we have tested in our in silico study. This is RNA dependent RNA polymerase from SARS-CoV-2. Here authenticity is 87.5%. That means the total 861 number of amino acid residues, that means 87.2% residues are located in the most favored region, that means in the red region. And H2, this is a very authentic structure. Its authenticity was 96.4% because 609 number of amino acids, this percentage are located within the most favored region, that means in the red region of the Ramachandran plot. and these are the two target. These are the two ligands. That means bioactive phytochemicals. This is the cajanus cajan plant. This is flower. This is leaves, stem. And these are the twigs and the pods containing the seeds. All these parts of the plants are showing medicinal activity against different types of pathogens, as well as these are utilized against different types of non-infectious diseases. Its roots are also very important for medicinal activity. So Caja isoflavone with PubChem ID 44257320 and Caja non PubChem ID 325518 are utilized as ligand molecules to be docked with the target proteins. So at first we have docked Caja isoflavone as well as Caja non. This is helicase, and we are seeing that this is the pocket that we have prepared in this web server, pocket10. This is a program for pocket identification and protein structure, because the location of the ligand within the pocket of the target protein is very essential. So we have prepared the protein of this helicase enzyme target protein, and after that we have performed docking studies, molecular docking, and this is blue color, Caja non and Caja isoflavone in magenta color. This is here, both the ligands are located within the pocket, so docking was done successfully, and this is the Caja isoflavone in the protein where it is located with helicase, and this is Caja non located within the same place but in slightly different position within the same pocket. And the interaction is like this. These blue color materials are the different amino acids of the helicase protein, target protein from SARS-CoV-2, and this is the ligand Caja isoflavone. Here we are seeing that hydrophobic interactions are 3, and these are forming with leucine, proline, and tyrosine. These 3 amino acids took part in the formation of hydrophobic bond. This is hydrophobic bond. These dotted lines 1, 2, and 3, and another 1, 2, and 3 continuous blue lines are representing with amino acids are hydrogen bonds. These amino acids that form the hydrogen bonds are arginine, histidine, as well as arginine. The number 409A, 554A, and 56. This is the mechanism, and due to their binding, that means the binding between helicase and Caja isoflavone, the binding energy was very low, and this is very important to note for their interaction authenticity, and the value was minus 8.4 kilocalorie per mole. And this is another ligand Caja non that formed the complex with helicase. These are the complex, this is ligand, and the blue colors are the amino acids of the protein helicase. And here we are seeing that 2 hydrophobic bonds are seen. Here this is 1 and 2, these dotted lines, and the histidine and alanine were the amino acid taking part in the formation of hydrophobic bonds, and hydrogen bonds, there are 5 in number. The amino acids were glycine of same number, and lysine 2881, and arginine 443A, and glutamic acid for 540A. And these are the bond distance, and these are the bond angles. And another protein, this is the RNA dependent RNA polymerase. This is RDRP. Actually, we have also prepared for this protein the pocket. This is the pocket located within the molecule of protein, that means the RDRP. And here we are seeing that blue color and as well as yellow color ligands. These are the pose of the ligands within the pocket of the target protein. Blue color is Caja non, and blue color is Caja isoflavone, and yellow color is Caja non. And the position within the RDP of Caja isoflavone and Caja non are here. and in case of here, this is the same positions within the same pocket they located, and this is the interaction between RDRP and isoflavone. 5 hydrophobic bonds and 3 hydrogen bonds were formed, and binding energy were minus 8.4 kilocalorie per mole, and docking interaction between RDRP and cajanone, 4 hydrophobic bonds as well as 3 hydrogen bonds were formed in the interaction between the RDRP as well as cajanone. And these are the interaction and that we obtained from Philip server. Binding energy was lowest among the all ligands, all interaction. It was minus 9.1 kilocalorie per mole. So this ligand was very active to inhibit the RDRP. And this is the third protein, which is H2 subunit of spike protein of SARS-CoV-2. This is the pocket where the two ligands, cajanone as well as isoflavone, respectively with blue color and magenta color, are located within the pocket of the H2 subunit of spike protein. And this is the isoflavone, and this is cajanone within the complex of H2 isoflavone and H2 cajanone. And this is the interaction. 3 hydrophobic bonds and 3 hydrogen bonds are formed in this interaction. These are the amino acid, this is ligand, and binding energy is minus 8.3 kilocalorie per mole. And this is another complex formed with H2 subunit and cajanone, the second cajanase cajan phytocomponent. And the interactions were 4 hydrophobic bonds and 4 hydrogen bonds. These are represented here with different types of amino acids of the protein, such as aspartic acid, serine, and glutamine in the formation of hydrogen bond, and in the formation of hydrogen bond, isoleucine, asparagine, and lysines took part, and the binding energy in the interaction are minus 8.3 kilocalorie per mole. And this is pharmacokinetic properties of ligands. ADMET analysis you utilize to server Swiss ADME as well as PKCSM tools. We followed for Lipinski's rule of 5 and bioavailability radar, and 6 parameters were utilized in this bioavailability radar formation. These are the solubility, size, polarity, lipophilicity, flexibility, and saturation. And this is the result from the Swiss, and this is the result from the PKCSM tool for ADME profiling. That means absorption, distribution, metabolism, excretion, and toxicity. And these are the features represented here. And for Lipinski rule, we are seeing that its molecular weight was less than 500 gram per mole, and its log P value was greater than 5 rotatable bonds are 4, and hydrogen bond acceptors are less than 10, 7, and donor 3. So we are seeing that this is a very good ligand following the Lipinski rule of 5, though one criteria was not achieved by isoflavone, that is due to log P value, which is more than 5. And this is the excretion and toxicity. We are seeing that the isoflavone, this is isoflavone, it is negative to amylase. That means it has no carcinogenicity, as well as it did not show hepatotoxicity as well as skin sensitization. So this isoflavone is a very good phytochemical obtained from cajanase cajan to be utilized against SARS-CoV-2. And this is bioavailability radar. We are seeing that except X log P, all the values were located within the pink region. That means the size, topological polar surface area, log S is all, and number of rotatable bonds, and fraction CSP3 value. So we are saying that its bioavailability score is 0.55. That means it can be orally consumed and may be absorbed in the intestine. And this is another ligand obtained from the cajanase cajan plant, CJNN, that means cajanone. We are seeing that its molecular weight is less than 500 gram per mole, log P value is less than 5, its hydrogen bond acceptor is less than 10, that means 6, and bond donor is less than 5, which is 3. So this cajanon obtained from the Cajanus cajan plant is a very good ligand that followed Lipinski rule of 5 with all criteria. And this is the ADME profile: absorption, distribution, and metabolism, excretion, and toxicity. M toxicity was also negative for this cajanon, as well as it was negative to hepatotoxicity and skin sensitization. And formation of bioavailability radar, except X log p value, which was greater than 5, all the criteria, size, total topological polar surface area, log S ESOL value, as well as number of rotatable bonds and fraction CSP are located within the pink region. So this is a very good ligand with the bioavailability score is 0.55. That means it is orally bioavailable. So that along with the Caja isoflavone, cajanon may be utilized as a orally bioavailable lead molecules to be utilized in the formation of drugs against SARS-CoV-2. And this is boiled egg presentation, W log P value versus topological polar surface area. Here 4 different ligands are presented, but we have studied for 2, Caja isoflavone and cajanon, number 1 and number 3. This is Caja isoflavone and this is cajan number 3. This is cajanon 1 and 3. So we are seeing that within the boiled egg, here this is the white part of the egg and this is the yellow part of the egg. No one molecules are located within this yellow part, so these are not blood-brain barrier positive, but these have good intestinal absorption capacity, and because these are located within the white region of the egg, boiled egg study. And here we are seeing that PGP protein were negative. The all were red, that means 1 and 3, along with 2 and 4, all the ligands were PGP negative. So ultimately the highlights, the Cajanus cajan bioactive compounds, 2 compounds were utilized, Caja isoflavone and cajanon, showed inhibitory activity against RNA dependent RNA polymerase, helicase, and S2 subunit S protein of SARS-CoV-2. So these inhibited the functioning of these 3 target proteins obtained from SARS-CoV-2, and molecular doping studies authenticated their inhibition and of all the 3 target proteins obtained from the SARS-CoV-2, and stable protein ligand complex formation was due to high binding affinities that were presented during the study of the ligands to the target protein. Pharmacokinetic predictions signify the usefulness of Cajanus cajan derived phytochemicals against COVID-19. So it can be clear that Cajanus cajan is a very good food plant that have the medicinal activity, and its phytocomponent, that means the Caja isoflavone and cajanon obtained from Cajanus cajan may be utilized in the compartment of SARS-CoV-2 when there is no specific drug, although the vaccination has been studied worldwide. And these are the publications in the field of COVID-19. And I acknowledge 3rd online international conference on nutrition and nutraceuticals 2021 organizing committee organized by Coalesce Research Group for the recognition of my research and supporting me for this presentation. Thank you. Stay safe, stay healthy.
Thank you, Dr. Shyama Padamandal, for your presentation. Is anyone having any questions?
Thank you, ma'am.
Okay, no questions from anyone. Thank you once again for your presence and presentation.
Thank you.
So our next presenter is from Dr. Neelam Kapur from Lakehead University, Canada. Hello, Dr. Neelam. Are you ready now?
Yes, I am.
So
Can you hear me?
Yes. Yeah, you are the new presenter now. Can you try to share your screen with us? If not, I have your presentation also. I
Okay,
can share my screen.
I can try. Let's see.
Okay. Yes, it's visible now.
Not sure what's happening. Can you see the screen? I can.
Yeah, but the screen is hanged, I think.
Something is going on, not sure. This is really weird. I have no idea what's going on. Shen, can you hear me?
Yes.
But nobody can see my screen, am I right?
Yes, we can able to see your screen.
You can?
Yes, I can able to see your screen, but it is not functional properly.
Right.
So shall I share my screen? You can like explain from this from your side.
Sure. Let's try that.
Okay then. So I will be sharing my screen now. Can you able to see my screen?
Yes, I see.
Okay.
So now you have control, right? When I say next, then you will change the slide.
Yes, yes, definitely. Once you say the next, I will definitely. Okay, you can start your presentation.
Well, thank you. Thanks to you, Sharon, and the organizing committee for the invitation.
I'm sorry, Dr. Neelam. There's some disturbance in the sound. It's like a coming echo.
Yeah, like same here. I'm not sure. I don't know what something wrong with the settings. How about now? Is it better?
Yes, now it's proper.
Oh, good. Not sure what happened. Sorry about that. So without taking any further time, I'll start. So my presentation is on looking at the effects of blueberry extract on norepinephrine-induced oxidative stress and apoptosis in a cardiac cell line, which is H9C2. Next. So I know Dr. Natikaran this morning very elegantly went over sort of the background on heart failure, the physiology of heart failure. So I won't go into that much detail, but just to summarize, so heart failure is a leading cause of morbidity and mortality. It's basically a pathophysiological condition in which the heart is not able to work efficiently, or in other words, it's not able to meet the metabolic needs of the body. So it's a syndrome. It's not a disease, and it's primarily dominated by hemodynamic changes and also changes in the neurohormones. As you can see in this slide here, neurohormonal activation includes things like sympathetic nervous system activation, as well as renin-angiotensin aldosterone system. Again, I'm not going to be going into too much details of this because I know Dr. Netkin again went over a little bit on the renin-angiotensin system. So basically, the activation of this system contributes to what we call cardiac remodeling, which includes things such as hypertrophy, apoptosis, fibrosis, necrosis, just to mention a few. And if left untreated, basically it can advance to impaired contractility and relaxation, leading to heart failure. Next. In our lab, in addition to looking at oxidative stress, we are also interested in studying inflammation. And I just wanted to give you like a big picture, like an overview of what our understanding is of the major players in the pathophysiology or the progression of heart failure. So in addition to oxidative stress, there is inflammation, which is an integral component of the host response to injury or a host invasion. So there are various pathologies that can lead to activation of the neuroendocrine system, increase in inflammation and oxidative stress. So they are not, I would say, they're not independent of each other. They operate simultaneously, leading to cardiac remodeling and cardiac dysfunction. But for today's presentation, I will primarily be focusing on oxidative stress. Next, please. So again, a few of the presenters this morning have already covered the basics of oxidative stress and reactive oxygen species mediated cell injuries. So again, very briefly, oxidative stress is an imbalance between free radical production and antioxidant enzyme system that scavenges those free radicals, leading to oxidative modification of cell membranes, so altering membrane structure and function, attacking or targeting the proteins and enzyme, again, affecting the structure and function of those, causing DNA damage, chromosomal aberrations, and leading to alterations in gene expression. So there are various methods of measuring oxidative stress. In our lab, we look at aldehydes, which is like a stable byproduct of lipid peroxidation, but we have also in the past studied lipid hydroperoxides or looking at thiobarbituric acid reactive substances, as well as studying enzymatic and non-enzymatic antioxidants. And just to name a few, like superoxide dismutase, catalase, glutathione peroxidase, as well as reduced and oxidized glutathione. Next, please. Okay, so based on what I have covered so far, the primary rationale for our study is, as I mentioned, that numerous studies have reported that there is enhanced sympathetic system activation, and in this case, we're using the example of norepinephrine, so which contributes to cardiac remodeling that leads to oxidative stress and cell death that progresses to heart failure. So this has been documented before, and we also know that in terms of antioxidants, that consumption of berries, small berries, which are rich in polyphenols, have a strong association between reduced risk of cardiovascular disease. So based on that, I would say our general hypothesis was that blueberry extract may help maintain or attenuate redox balance and also improve norepinephrine-mediated cardiac cell damage. Next, please. So our primary aim was to evaluate the effect of this extract on H9C2 cardiac cell line that were exposed to norepinephrine by measuring various markers of apoptosis and oxidative stress. So we basically had 4 different conditions. So control cells were exposed to serum-free media, and then for blueberry extract, cells were pre-incubated with 50 microgram per ml blueberry extract in serum-free media for 4 hours. And then we had cells that were exposed to norepinephrine for 24 hours alone. And then we had combination, so where we had 4 hours of pre-exposure to blueberry followed by cells were then further incubated with norepinephrine for 24 hours. And these concentrations will be, and then the concentrations for norepinephrine, which is 100 micromolar, and blueberry, which is 50 microgram, were based on a previous study where we had looked at cell viability. Next, please. Okay, so the first set of data. So this is looking at cell death or apoptosis. So apoptosis was measured using the Caspar-TAG caspase 3-7 assay system, where caspase positive cells were basically assessed by flow cytometry. So this is based on fluorescence in the presence of fluorochrome, which is the inhibitors of caspases. And the way we measure caspase is by actually looking at mean fluorescence intensities. So as you can see in this slide here, that exposure of cells to norepinephrine led to an increase in active caspase 3-7 positive cells, and then blueberry treatment basically prevented that increase. And this was evident both using flow cytometry, so looking at caspase 3-7 activity as well as protein levels, protein expression. Next, please. Moving on to oxidative stress, we looked at a few parameters of oxidative stress, but in the interest of time, I'm only showing you one. So we looked at 4-HNE, as I mentioned, which is a stable byproduct of lipid peroxidation. So you can see that it's like protein adapt formation, and you can see there was a significant increase in 4-HNE levels upon exposure to norepinephrine, and was significantly attenuated in the presence of blueberry extract. Next. Next, please. Okay, so we looked at 3 enzymatic antioxidants: manganese superoxide dismutase, glutathione peroxidase, and catalase. So manganese superoxide dismutase basically superoxide anion, and you can see that it showed decreased protein expression in norepinephrine cells compared to the control cells. And pre-treatment with blueberry extract basically maintained SOD protein levels near control levels. With regards to glutathione peroxidase, which is responsible for the reduction of hydrogen peroxide and lipid hydroperoxide, it was also decreased in norepinephrine compared to control cells, and then they were maintained in the cells that were pre-treated with blueberry extract. Next. Okay, so the last antioxidant we looked at was catalase, which decomposes hydrogen peroxide to oxygen and water. So there was again a decrease in catalase in norepinephrine treated cells compared to control, and then blueberry extract pretreatment basically attenuated the decrease in its expression. So based on this data, oxidative stress and antioxidant data, we can say that blueberry extract indeed protected cardiac cell or H9-induced cells by maintaining the antioxidant status and by decreasing 4-HNE levels, suggesting that blueberry extract does protect cells against oxidative stress and promote cell survival. Next, please. So we were further interested in looking at the downstream signaling. It's one thing to show a correlation in terms of what happens with oxidative stress and cell death, but what is the underlying mechanism behind this protective action of blueberry extract? So we looked at here in this slide, you can see we looked at FOXO3A. Basically, so FOXO3 proteins are a family of transcription factors that play an important role in regulating genes that are involved in oxidative stress and basically promoting cardiomyocyte survival. So you can see here that basically exposure to norepinephrine increased phosphorylated FOXO3A, the ratio of FOXO3A to total FOXO3A compared to control. And what was interesting is that blueberry extract pretreatment basically increased its activity even further compared to control. And we know that FOXO3A can be inhibited by AKT, which basically blunts the activation of genes that are related to antioxidant response. So you can see that phospho-AKT to total AKT ratio was also increased in cells exposed to norepinephrine, and then blueberry treatment basically attenuated this increase when you compare it to control. Okay, so see, the take-home message is that upregulation of FOXO3A, it may occur as an attempt to protect this H9C2 cells from oxidative damage that's induced by norepinephrine. Okay, next please. Then we looked at another transcription factor, which is STAT3, signal transducer and activator of transcription. So STAT3 activation inhibits caspase-3 activation and regulates transcription of various pro-survival genes. And we also looked at AMPK alpha, which is known to be activated by also by oxidative stress and is an important regulator of STAT3 phosphorylation. Okay, so again, exposure of cardiac H9C2 cells to norepinephrine led to decrease in phosphorylated STAT3 to total STAT3, and while blueberry extract pretreatment attenuated this. So you can see that norepinephrine caused an increase in phospho-AMPK to total AMPK ratio compared to control, and blueberry treatment did not alter this activity. So now, considering that AMPK alpha also has an important role in other signaling pathway, we did look at mTOR and P70S6 kinase, but I think again, in the interest of time, I'm going to skip that slide. So if we can go to the next slide and skip this one. Okay, so basically, like I mentioned, we have done an in-depth study in terms of looking at various signaling molecules that are involved downstream of what happens with oxidative stress and inflammation. But I just wanted to give you like a broad overview of what we have seen in this study. So based on what I have presented, I can summarize that norepinephrine elevated oxidative stress as demonstrated by an increase in 4-HNE protein adduct formation. And we know that 4-HNE protein adducts with protein basically leads to cell damage and promotes cell death or apoptosis, eventually leading to cardiac dysfunction. We have also demonstrated that norepinephrine blunted the protein expression of catalase, superoxide dismutase, and glutathione peroxidase. So collectively, based on this data, we can say that blueberry exposure prior to incubation with norepinephrine modulates redox signaling by mitigating oxidative stress and resulting in attenuated cell death. Next, please. I'd like to thank my team members, includes both my students, 2 PhD students and 1 master's students and technician, and also my collaborators who were very, very resourceful in terms of providing us blueberry extract and also with some of the techniques. Next, please. So with this, I will end my presentation, and I'm happy to take any questions.
Thank you, Dr. Neelam, for your presentation. Is anyone having any questions? Okay, no questions from anyone. Thank you once again for your presence and presentation.
Thank you very much, and really sorry about all the...
Yeah, there's no problem. It happens as it's online, so it happens. There's no problem. So moving on to our next presenter is Dr. Leonard Z. Horowitz from Medical Veritas International, USA. Hello, Dr. Leonard. Are you ready with your presentation? Hello? Yeah, hello, Dr. Leonard. Are you there?
Hello, 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 hello.
Yes. Yeah,
Yes,
you are the new presenter now. Yeah, can you please share your screen with us?
I would love to. How would you like me to do that?
Yeah, you have a screen button at the bottom of your screen. That's the
Uh,
third button. You can click on that.
At the bottom of my screen, I don't see that.
In
Uh,
your screen, you have a 4 buttons, right? At the bottom, at the
oh
center
yeah,
of the
yes, yes, yes.
bottom. The
Screen.
first one is mic, second one is camera, third one is screen.
Yeah, so I see
Yeah,
that.
click
I'm
on
clicking,
that. Click
and
on that.
it says go to meeting. It says not now. I get a pop-up that says go to meeting needs to use accessibility
Yes,
feature.
yes.
It
Yes,
says,
you need to give the permission.
okay, all right, let's see. All right, let's try it again. Nope, it's giving me the same prompt. If I say open preferences.
Okay.
All right. Yeah, I'd love to share the screen with you. If I click on that, see, I have the camera
Okay.
on, I have the mic on, and I'm
Yes.
trying to. I click on the screen and it says accessibility features include keyboard, mouse, and it basically it's important. When you're done, restart GoToMeeting to apply your changes. Open system preferences or not now. That's the only option.
Okay. So you can do one thing. Can you send the presentation to Sharon Charles?
I can try. How would you like me to do
Yeah,
that?
then I will play from my end.
It's in a
The
PowerPoint.
mail ID has been given in the chat box just now. Just let me paste it once again.
Okay, I have a PowerPoint presentation.
Yes, yes, you can send it to, like I have just messaged you in the chat box.
The chat box. Now I gotta find that.
Yeah, you can see the mail ID that is sherincharles.coalesceresearch@gmail.com. Can you please send it to that email ID?
I can try.
Chat box right
Yeah.
here.
Once you send it to that, can you please inform me? I will take it from the Sherlyn Charles.
Send it to the chat box.
Send it to the chat box. I see all the doctors listed. Everyone. Okay, I see. I see. Charles is Sharon Charles.
Is that her? Is that her?
Okay. So now I have to attach the PowerPoint. How do you get that?
Okay, once you send it to that, please let me know.
Oh, it's this email. Copy and paste. No, let's copy and paste.
This one?
No, you need to go to your email and send it.
What?
Do you want to turn your camera off?
No, I've got it. Well, it's.
Let's see.
Okay, I send this to Charles, maybe. Charles. Let's see. Okay, I just sent it. I don't know if you can get it. I just sent it by.
Okay. Yeah. I will be taking from Sharon Charles.
Yeah, I just sent it
Allow me a
via.
few minutes.
Did you get an email from me with the PowerPoint presentation attached?
Yeah, just a minute. Just allow me for 2 minutes. I will be taking from Sharon Charles.
All right, thank you.
Okay.
I'm sorry, are you there?
Yeah, doctor, I received your presentation.
Wonderful.
Yeah, I will be playing right now. Just a minute.
Okay.
I will be sharing my screen now. Can you able to see my screen?
No, but yeah, now I do. I see your screen
Okay,
now.
just a minute. Yeah.
Okay, sounds good. Thank you.
Yeah, I'm going to be playing the full video. Yes. Is it perfect now?
I think it's perfect, as best we can
Okay,
get.
then you can let me know once you want to change the slide.
Oh, I see. You're going to have to change. Oh, my goodness. Okay, that's a shame. All right. Well, thank you so much. Shall I begin?
Yes, yes, you can begin.
Okay. Well, this is a very unusual presentation. It's very, very different from the scientific presentations. That's not to say that it's not based on substantial science, and there's scientific references already that I'll share a couple of them with you. But it's an extraordinary presentation that virtually shatters the whole medical paradigm. And it really is vitally important to consider nutraceuticals and the role that nutraceuticals will play. From the abstract that I presented, after 1,000 years of Bible code sequestering, that is, codes that were in the Bible that were secreted. In 1997, the original 6 musical scale notes from the solfeggio frequency scale were recovered by a Dr. Joseph Paleo, presumably by divine revelation, from the book of Numbers. So you don't need a computer to see these numbers. You can actually go in, you can see the code in the book of Numbers. A year later, I published Dr. Paleo's intelligence in a book that is called Healing Codes for the Biological Apocalypse. The book became a national bestseller, and I continued researching the sounds of the solfeggio musical scale. The third note was of sensational interest to me, and also musicians and natural healers worldwide. Vibrating at 528 cycles per second, that's Hertz frequencies, Dr. Paleo identified that this pure, called mi note, M-I, tone, derives from the miragistorum word in Latin, which means miracles in English. Subsequently, many facts caused me to claim that 528 was not only the key of the house of David used by King David in the Old Testament to heal Saul's troubling evil spirits, but also, as I continued to research with some of the world's leading physicists and mathematicians, I learned that 528 frequency resonates at the heart of musical mathematical matrix of divine creation or divine design or intelligent design, whatever you want to call it. I had to conclude from this that 528 is pure tone love, and the real Da Vinci Code is intimately connected to this. This truth is evidenced throughout the botanical world, getting into the understanding of how important this is in nutraceuticals and the development of subsequent research and developments in the field of nutraceuticals and pharmaceuticals. It administers life miraculously, this frequency does, through an energy transfer, starting with central sunshine. This 528 electromagnetic radiation is reflected in the greenish yellow color of chlorophyll that vibrates at the heart of rainbows. Nearly identical to hemoglobin, it is, the oxygenating structure and the piezoelectric antioxidant function that some of your previous presenters have already discussed, the importance of their scientific research and developments in this whole field of antioxidant therapeutics. The good vibration of 528 also predominates in water and ocean waves that produces life-sustaining oxygen from H2O. Recognizing that music is the universal language, pure love is the universal healer, and water is the universal solvent. I encouraged years ago NASA scientists and their agents to advance a nutraceutical alternative to vaccinations and antibiotics called oxysilver with 528. Subsequently, the piezoelectric antioxidant immune boosting efficacy of simply the 528 pure tone wave, that alone was confirmed independently by peer-reviewed studies of Dalari et al. In India, published in Genes and Genomics, and also Babaye and Riezi in Journal of Addiction Research, Therapeutics from University of Tehran. Both groups independently decided that they would research this 528 wave and found extraordinary things, wonderful things about it, powerful things about it. So in this overview, I'm going to simply summarize revelations in this 528 bioresonating field, including pharmaceutical industry's interests, because right now, Pfizer, Moderna, the most advanced pharmaceutical companies, their leading officials are actually heavily investing in 528 and actually frequency therapeutics. In fact, one company that is directed by, on the board of directors by Pfizer's leading science expert, has established frequency therapeutics company. And it relates to also the work that I've been doing in frequency rehab, using this understanding to virtually revolutionize all of music and medicine. We see now recording artists, and Google, YouTube is full of presentations now that are associated with the research that I've been doing. Okay, so next slide, please. If you understand 528 and what it is, again, it's the heart of sunshine. Keep going. Next slide, please. Yeah, if you can just give me the next slide, I appreciate it.
Definitely.
Okay, sounds good. One more, advance one more. I'm going to have to go fairly quickly here. If you simply consider the fact that about 80% of life on Earth, including the human body, approximately, is water, and 20% is lava rock. All the minerals come from virtually lava rock. And lava rock in that stone has precious gems. It outputs frequencies of energetics. And in fact, there is very unique structured water that plays an intimate role in DNA, the function of DNA in photon emissions and intercellular communications, what's called cellular upregulation, meaning literally the tissues and cells are coordinated to manifest life, manifest each of us virtually instantaneously. Every nanosecond, we're really literally being remanifested in this electromechanics. And so this whole concept is vitally important to understanding. Next slide, please. That my concept, my theory, my claim is that pure tone, love, 528, is at the heart of this magnificent universe that functions this way. Please keep going. You're way behind me in the slides. Okay, so the color of grass. Why is grass green? Why is chlorophyll? Why is it that color? Next slide, please. The concept that, go ahead, advance one more, please. That's good, thank you. The concept that you have central sunshine and that the whole environmental issues with the non-renewable resources, the carbon pollution, and all of this has a direct link to this understanding at the most fundamental level of energetics, bioelectricity, the antioxidant capability. Of course, we know water being the universal solvent has the capacity to clean it all up. And of course, when you look at a human being, you look at detoxification strategies to purge the bloodstream of toxins, pollutants. And again, this is kind of like miraculously how that occurs. Next slide, please. So yeah, thank you. So really, you are the music. We are the music. We're a manifestation, a musical miraculous manifestation of what, in my opinion, is divine frequency vibrations, because we even as scientists and experts and scholars can't even conceive of the brilliance of the creator of the universe who's actually put all of this together. Next slide, please. So if we were to now consider what are the special elements or the aspects, next slide, please. If we can consider what it is that 528 makes it so special, and look into some of the aspects of it that play into this miraculous manifestation of life and rejuvenation and health maintenance that we seek in the nutraceutical field. First of all, we have to understand that 528 is linked to the heart of everything. As above, so below. If it's true for the heart of sunshine, that greenish yellow color in a rainbow, then you know that's true for the electromagnetic color spectrum of the sun, which is solar radiation, which is hydrogen popping off the electrons. I call them the electrons of love. And that ultimately, that's what gives us the heart of the rainbow. As above, so below. If it's true for the rainbow, it's true for the sun, it's true for probably God's heart and my heart and your heart. So it's fundamental to virtually life. It plays also at the heart. 528 does of the solfeggio musical scale, which is linked to the musical mathematical matrix of creation. And that's why it's fundamental to pi, phi, the Fibonacci series, and the golden mean. That's why it's also required for space-time measurement. That's why it's also associated with the sacred geometry of circles. That's why there's in measurements, there's precisely 5,280 feet in a measured mile. 5,280 feet, that's a 528 absolute certainty. And then it's also connected to the speed of light. You would not be able to actually measure and have the speed of light without 528. It's central to water structuring, which I'll mention a little bit more in a couple minutes. And it's key to God's love, in my opinion. And it's also, I'm claiming that it's central to the biblical key of the house of David that King David played his healing harp with. As I mentioned, next slide. Actually, you're a little bit behind. One more. Go ahead, one more. Thank you. And it resonates, as I mentioned, to the heart of rainbows and snowflakes. Actually, the snowflake designs, which I'll show you in a slide in a minute, has this frequency of 528. If you do the numerology, 5 plus 2 is 7 plus 8 is 15. Then you add the 1 plus 5, that's 6. Now you're looking at carbon 6. The reason why we are organic beings in the organic chemistry is based on this sacred geometry of 528 frequency of resonance. And it's associated, as I mentioned, with light, sound, frequency signaling of electrogenetics. and central to chlorophyll. If you look at the structure of chlorophyll, it's nearly identical to hemoglobin, which circulates the oxygen to restore our entire functioning based on, again, this piezoelectricity of the electrons being delivered via this organic chemistry molecule. And so, I mean, we really could go on, and basically, next slide, please. It's essentially to understand that when we're dealing with people, we're dealing with the creative juice, we're dealing with water. And photograph on the left, you see actually Da Vinci studying water. This is an old man water slide. And the understanding of how important this is was central to the ancient mystery school Pythagorean mathematics, by which the first book in science, which was called Physics, was created by Aristotle, based on this school of reasoning and observing nature and its full magnificence and how it's connected musically, mathematically to creation. So next slide, please. Here you have developed by Russian scientists images of space water, and that water is found all over the universe to actually, beyond our atmosphere. And there's water that's been discovered on Mars, under rocks, in deep space, in crystal formations, and that this essentially indicates what is the fundamental structure of the carbon-6 also. It reflects that energetics. Next slide, please. And here on the lower left side of the image, you can see from Robert Sakeley, who's Professor Emeritus at University of California, Berkeley, looking into the special water that's called structured water that is in DNA that permits to optimally function. In fact, Dr. Sakeley et al. Shared and proved and witnessed and reported multiple times on if you reduce the amount of this special structured water out of DNA as little as 8%, then the actual genetic strands fold over and their electromechanics degenerates dramatically. It reduces the capacity of that light and sound signaling, the photon-phonon emissions for intercellular communications, by which restoration and rejuvenation and healing occurs. Next slide, please. So getting into this concept of coronavirus now. I'll finish my presentation. I just have a couple of minutes, and I'm not sure we'll have any questions, but essentially where we're at with coronavirus currently is the thesis that I initially advanced long before anybody else as the editor-in-chief of Medical Veritas International Journal, is that this was a laboratory creation. There's no doubt right now. Actually, currently, I have a lawsuit against Pfizer and Moderna for unfair and deceptive trade and censoring and concealing, most important, genetic science and genetic studies. They were not well tested, the vaccines that currently exist. But the fact of the matter is, if we were to simply consider how does the coronavirus work, how do the antigens, for example, from the mRNA vaccines get into the human body, you have to understand the delivery mechanism deals intimately with this antioxidant preventative capabilities. You see, the spike protein, that is the attachment apparatus, besides having concealed the HIV envelope gene sequences in that spike protein, besides concealing that, the vaccines actually work through what's largely concealed. It's not well known. It's known in the scientific circles and communities in which you and I basically engage. But the hydrogel lipid hydro water mechanism deals with the attachment of the virus, of that spike protein attachment mechanism, to the electrically charged, negatively charged surface membranes of the cells. And so delivery of the mRNA, what's called the payload by the vaccines, is contingent upon the positively charged spike protein that attaches magnetically to the negatively charged surface membrane of the human cells, and that then facilitates and permits the injection into the cell of the mRNA, which corrupts the DNA. And ultimately, in the case of the vaccinations, it simply calls for the DNA to output more antigens of the same spike protein. So that's in essence what your COVID vaccines are all about. But this has a great meaning and expansion beyond the science and beyond even the politics now that we're witnessing and the impositions of the COVID pandemic and what it's doing to society. One has to actually look well beyond what is traditional science or what is considered standard science, standard practice in how science is, and consider the politics and economics of what we're witnessing. And ultimately, that's my current research. I'll end here by simply saying to you that those, again, top officials at the highest levels of both pharmaceutical industry, government, are investing heavily in frequency therapeutics, and among all of the frequencies that have the potential to benefit humanity through particularly nutraceuticals. Again, nutraceuticals, you have to understand, can be impregnated through the energy vibrations, the understanding of water, water structure, the understanding that water holds memory. For example, homeopathics is a practical application in the field of medicine and health science of this precise mechanism by which water structuring within whatever nutraceutical even, or botanical even, holds this memory, and that ultimately is transmitted via a piezoelectric and electromagnetic mechanism to the individual who is likewise full of water. Water is a liquid crystal superconductor of sound and light energy, plus it holds memory because of the sacred geometry. So if you want to design nutraceuticals to optimize whatever benefit you're intending to provide, you would obviously consider putting 528 frequency into the formula, because it not only reflects the heart of nature, not only reflects the heart of love, which is essentially our intention to help human beings most lovingly. With faithful, loving intention, we can literally produce miracles, says the religious world. If you put that intention into your formulation for the development of nutraceuticals with 528 frequency coupled and that transmitted, then that would optimize what it is that we intend to do in our healthcare professions. And also it reflects and keeps up with the most advanced science in the field of pharmaceuticals that those who are engaged in COVID research and developments have been engaging. So thank you very much. I'll take any questions that you have.
Thank you, Dr. Leonard, for your presentation. Is anyone having any questions? Okay, no questions from anyone. Thank you once again for your presence and presentation.
Thank you so much. God bless. Bye-bye.
Bye. So by this, we came to end of our day 2 webinar. I would like to thank all the attendees and participants of today's webinar. Hope you enjoyed this and gained the knowledge also. And we'll be glad if you could join us in our next webinar, which will be scheduled and the dates will be informed to you by mail. We will be very happy if you could share your opinion or feedback with us. Thank you for making the webinar successful.